Psychiatric History and Mental State Examination, Part 3 of 4. In the first two parts, we talked about the components of the psychiatric history. In this section, we're going to talk about the mental state examination. How would you describe the patient to someone who isn't there? When we're doing a mental state examination, we're essentially describing the patient to someone who isn't there and describing what they are like at that time. The mental state examination is a snapshot of what they are like at that time, and it's akin to the physical examination that you would do for someone who has a physical health problem or physical symptom. So let's say somebody presented to accident and emergency with symptoms of shock and sepsis and abdominal pain. You would check their vital signs, you may feel their abdomen. That is what the mental state examination is equivalent to in terms of the psychiatric assessment. So we're looking at signs on examination at that particular time. So the mental state examination is split up into different sections. We start with commenting on the appearance and behaviour. We comment on their speech, their mood and affect, their thoughts, perception, insight, and cognition. Many of these things you will have noticed before the mental state examination. So the psychiatric assessment starts as soon as the patient walks through the door. As soon as you first set eyes on the patient, you should be considering that as part of your assessment. So when you're taking the history, you would have already noticed some things about their appearance and behaviour and their speech and what their mood objectively looks like and what their affect is like. But the mental state examination is split up into these components because it's a systematic way of recording each section, and when we do things in a systematic way, we are less likely to miss things out. So let's start with the appearance and behaviour. I'd like you to pause the video and write 7 things that you would comment on with regards to somebody's appearance and behaviour. Then I want you to discuss these in your small groups. So you may want to comment on the person's gender. You may want to comment on the body habitus. Are they overweight, underweight? Are they unusually small or unusually tall? Comment on whether they're clean and groomed. Are they malodorous and dishevelled and unkempt? Comment on their hair or their clothing style. Is the clothing appropriate for that context and that situation? Say, for example, somebody is wearing flip-flops, t-shirt and very short shorts in the middle of January on a very cold day. It would be worth commenting that that clothing is not appropriate for the weather. Or, let's say, an example I can think of when I was doing a ward round in psychiatry, and somebody with mania who had an elevated mood and felt extremely ecstatic and happy attended a normal ward round dressed in a ball gown and with hair that looked immaculate and with makeup that looked immaculate and jewellery that looked absolutely extravagant. And it was worth commenting on that person was dressed very nicely in very extravagant clothes and looked like they were dressed for a ball, but was excessive for that ward round context. You might want to comment on any syndromic features. Have you noticed any unusual postures or any unusual movements? Have you seen any facial movements or facial gnawing? Have you seen any abnormal body movements such as hand wringing or hand flapping or fidgeting? Have you seen the person talking to themselves or responding to any unseen stimuli? Have you noticed them looking at a certain area of the wall and pausing as if very distracted? What is their eye contact like? Are they able to maintain good eye contact? Is their eye contact prolonged and intense? Are they avoiding eye contact and looking at the floor? Or is the eye contact fleeting? What is the rapport like with the client? Are you able to establish a good rapport so that the patient feels open and comfortable talking to you? Or are they quite irritable and hostile and you're not able to establish any rapport with them at all? Is the rapport superficial and minimal? Are they restless and anxious or calm and cooperative? Are they engaging or not engaging? Are they pleasant and polite or hostile and irritable? Now I want you to think about the speech. I don't want you to think so much about the content of what they're saying, because that comes into a separate section, which is in the thought section. But I want you to comment on a few things that you might want to, that you might notice about somebody's speech. So if you can write down maybe 3 or 4 things about someone's speech and pause the video now and discuss these in your small groups. So you might want to comment on the fluency and the coherency, the rate, the volume and the tone. So let's break these down. So in terms of things like rate, is the rate fast or slow? Is there lots of pauses and does it take them a long time to answer the question? So slow speech with lots of pauses may suggest perhaps maybe a sign of depression, but fast, rapid speech and pressured speech, when the client is expressing so much and feels like they have so much to tell you that it's difficult to interrupt them at times, that might be a sign of mania or hypomania. Are they talking quietly with a low voice where you're struggling to hear them, which might be a sign of depression? Or are they speaking very loud and shouting, and that might be a sign of mania? What's the tone like? Is it monotonous and monosyllabic yes/no answers, which is not spontaneous speech? That might suggest depression. Or is it fluctuating in tone, going from being very fast to very slow, or very loud to very quiet? All these things are worth commenting on. The next section is the mood. And mood is split up into the objective and the subjective mood. So objective mood is what you think that person's mood looks like. And then the subjective mood is what the client thinks their mood is like. So the objective mood is what the healthcare practitioner thinks that person's mood is like, and the subjective is what they feel their mood is like. And to assess that, you might want to ask the client how do they feel their mood is on a scale of 1 to 10. And that can be useful sometimes to monitor changes in mood. Or you could ask them, how would you describe your mood? Or what's your mood like at the moment? There may be a difference in the objective and the subjective mood. So whilst the patient may say that they feel very low and lethargic and depressed, objectively, you have to write down as the healthcare practitioner what you feel their mood is like, which might be euthymic, which means normal mood or within the normal ranges of mood. And that can sometimes mean there's a difference between the objective and subjective mood, or something we call an incongruence between the objective and the subjective mood. So the affect is a separate section, but I've just combined it into this one. And what the affect is the observed emotional state. So it's looking at the emotional expressions in the face and the emotional reactivity. So when somebody is happy or talking about something they enjoy talking about, like their family or their pets, you'll see in their face that it brightens up, so to speak, and they smile, and you can see it in their eyes and the facial reactions. And that is something we call reactive affect. Or if somebody is talking about something very sad, you might see them crying or looking a bit upset. Again, that's a reactive affect. They are reactive to the situation and the state that they're in. You may see some other types of affect. So a blunted affect is when there's reduced emotional reactivity in the face, sometimes seen in chronic schizophrenia. And it's one of the negative symptoms of schizophrenia. And you may see a flattened affect in severe depression when there's no emotional reactivity in the face at all. So if you give them good news or bad news, you can't see the emotional expressions in their face. Or you may notice labile affect, which can be seen in mania. And that means the emotional expressions are changing very rapidly from highs to lows. The next section is thoughts, and thoughts are split up into two things. Well, I like to split it up into form and content, though some books will also mention thought stream. But to simplify, I've just split it up into thought form and thought content. So when we're talking about thought form, what we're really talking about is the way they're putting the words together and whether that makes sense as a sentence. So can you follow what the client is saying? Are they talking in a logical way that you can have what we'd call a sort of normal conversation with them, that they answer your questions appropriately? Or is it difficult to understand them? And is there a difficulty in following what they're saying? In that case, it may be a formal thought disorder. And there's different ways to describe a formal thought disorder or a form of thought disorder. So a circumstantial thought disorder is when you ask somebody a question, they will go round and round in circles, and eventually they will get to the answer, but it will take them a very long time, and you may have to ask the question several times until they eventually give you the answer. Tangential thought disorder is when somebody will jump from a topic to a completely different topic, so go off tangent completely. And if they do that frequently, it's really difficult to follow what they're saying. You may also see something called flight of ideas, which is when people jump from topic to topic, and there's a loose association between the topics, but they're jumping from topic to topic. And if they do it frequently, again, it's really difficult to understand what they're saying. Some people may have something called a word salad, which is just a name for the type of thought disorder where someone is saying completely incomprehensible words and things that don't really make sense. There are many other types of formal thought disorder. You don't necessarily need to be able to know the name of each thought disorder, but it's definitely something you can comment on if you do pick up something like flight of ideas or tangential speech. If not, and if you can write out things verbatim, it will really help when somebody is trying to understand what kind of thought disorder that person has. The second part of the thoughts is the thought content, and that's the content of what that person is thinking. So what exactly are they talking about? Are they expressing any delusional beliefs at that time? Are they expressing overt delusional beliefs, where they're spontaneously coming out with that delusion? Or is it not so overt, where you've had to really probe them on that and ask them questions and challenge that to see if they're expressing those delusions? Are they preoccupied with anything at that time or at the time of the examination? Are they expressing any thoughts about hurting themselves or hurting other people? Perceptual abnormalities. So this section is really about assessing for hallucinations, or mostly about assessing hallucinations. And hallucinations are auditory. I've highlighted auditory because that's the most common type of hallucinations that are described. But of course, hallucinations can occur in any of your sensory modalities. So the next common one would be a visual hallucination, so seeing visions. So auditory being hearing voices, visions are visual hallucinations. Tactile, which is a touch type hallucination, so feeling like your skin crawling is an example of a tactile hallucination. And that would always make me wonder if somebody is withdrawing from alcohol or drugs, if they're describing skin crawling or abnormal tactile hallucinations. And olfactory hallucinations are hallucinations related to smell, or gustatory are to do with taste. So I have seen people with severe depression describe a constant smell of rotting food, or a constant taste of rotting food, and that's related to their severe depression if they've started to have psychotic symptoms, and these hallucinations may be present, which are congruent to the mood they're in, so the negative type hallucinations. Insight. So when it comes to insight, we're really thinking about insight into someone's illness or their own mental health issue. So can you think about 3 questions you could ask a client when you're trying to assess whether they have insight into their own mental health problem? And I want you to pause the video now, write down your thoughts and discuss them in your small groups. So the types of questions you could ask are, do you feel your symptoms may be related to a mental health problem? And one thing I want you to consider is that insight is on a spectrum. On one end of the spectrum, someone could have absolutely no insight at all into their mental health problem. And on the other end of the spectrum, someone can have really good insight into their mental health problem. When someone has really good insight into their mental health problem, that suggests that they are more likely to take their medications because they have a good understanding that their medications help to keep them well. Or they're more likely to engage with the mental health team and more likely to take on the psychological therapy if it's recommended to them and if they find it useful, and actively take part in that. When someone has no insight into their mental health problem, that's a bit like saying they don't think that their symptoms are related to a mental health problem, despite sort of evidence to the contrary, or despite what the mental health team or the psychiatry team are saying to them. So let's say somebody has severe schizophrenia and they've been in hospital multiple times, but when they are released, they don't have any insight into their mental health problem and they don't believe that they have schizophrenia. That person may not want to take medication because they don't believe they have a mental health problem, so they don't see the need to take a medication. They may not want to engage with any psychological therapy and may actively try to avoid any mental health team or doctors in general. And that might lead to relapses once they are discharged into the community. So other questions you could ask are, do you think that treatment can help you? Or do you think medications might be able to help you for your depression? Or would you like to seek help for your mental health problems? Or do you think psychological therapies can help you? Insight is very closely linked to capacity to make decisions about mental health. As I mentioned, if somebody has no insight into their mental health problem, that means they don't believe they have a mental health problem, then it's very difficult for that person to weigh up treatment decisions and weigh up the pros and cons of treatment. And for example, the pros and cons of taking an antipsychotic medication, because they don't believe they have a mental health problem. And for that reason, it is linked to capacity to make decisions about their mental health, because weighing up decisions, weighing up the pros and cons and the risks and benefits is an essential part of the criteria for demonstrating capacity. For somebody to have capacity, they need to be able to understand information, retain that information enough to be able to communicate their decision and weigh up that decision. So weigh up the pros and cons and the risks and benefits. You must be able to do all those things, which is weigh, retain, understand and communicate your decision to demonstrate capacity. The next section is cognition. So we can test this grossly or do formal testing. So you want to assess whether someone's conscious and alert, or are they drowsy. As a very basic screen, you can assess whether someone's oriented to the time, person and place. So do you know what day it is today? Roughly what time is it to the nearest hour without looking at the clock? What year is it? If you've introduced yourself at the start of the assessment, you can say, I told you who I was at the beginning of the assessment. Can you tell me who I am? Where are we at the moment? What is this building? Is it? And they will hopefully tell you if it's a hospital or a police station. And where are you? Which city are we in at the moment? So those are the simple questions you can ask to assess whether someone is oriented to their environment. You might want to assess someone's attention. Grossly, you should comment on whether they are able to concentrate when you're talking to them. You might want to assess their memory. So asking a few questions about something you asked them at the beginning. As I mentioned, you can test this grossly, just seeing if they're able to concentrate and oriented, or you can test this through more formal testing using either a 30-point mini mental state examination or a 10-point abbreviated mental test score. A mini mental state examination is a good screen for dementia or memory problems, but it's not a diagnostic test of anything. And throughout the whole psychiatric assessment, so when you're taking the history, when you're doing the mental state examination, we have to be thinking about the risk assessment. I document the risk assessment at the end of the mental state examination, but that doesn't mean to say I'm doing it at the end of the assessment. I'm doing it throughout the assessment. When you're doing a risk assessment, we have to think about the different risks that are present. So there'll be risk perhaps to the person themselves. There could be risk to others if they've expressed thoughts of hurting other people. Or there could be risks from other people. Are they vulnerable to exploitation due to their mental health problem? So that takes us to the end of part 3. And in the first 2 parts, we talked about the psychiatric history. In the third part, we talked about the mental state examination. In the next session, we're going to practice doing a mental state examination using a video I found on YouTube